Good morning, Dr. Mohana.
Good morning, Joanna. Thanks for having me today.
Super excited to have you. It was a little bit rushed for you in the morning. You had a last-minute patient, but that's okay. We'll roll with it. I think we're fine and ready to chat to our mummies here. So good morning, mummies. As you're joining, we're going to do some introductions. We've got Dr. Mohana. We're super excited to have a new pediatrician in the East. Congratulations to the
Thank you so much. Thank you.
Amazing. So maybe that's where we start. Where is your new clinic?
So my new clinic is actually located at Juchiat Road, and it's just right beside Little Farms and Katong Point, opposite Katong I-12. I used to practice at the Parkway East Pediatric Clinic, which was close by, and then have moved outside to start my own practice. So that's just started a couple of weeks ago. Yeah, I'm really excited about everything that's new over here. Yeah,
very good. And by what I've seen on Instagram, because I haven't been personally, but I will. It's really kid friendly. Like it looks so fresh and welcoming and child friendly and so on. So that's amazing. Yeah. I love that. Okay, Dr. Mohana, please, would you introduce yourself and tell us a little bit about where you come from, how you practice, what your background is, and so on, so the moms get a little feel for you.
Sure. So I am a pediatrician. So I trained locally. I studied and trained locally. I used to work at the National University Hospital. Some people don't know that we do have a pediatric department there. It's actually really good. It's actually the transplant center for children in Singapore, as well as the oncology center. So we are very subspecialized in terms of pediatric care. And with them, I actually trained in pediatric allergy and immunology. So that's where my subspecialty interests lie. So up till now, I do still see common cough, cold, general pediatric conditions, vaccinations, but I also continue my passion, which is pediatric allergy. So our clinic as well is specialized for allergy procedures. And I guess that's why we're having this talk today, to speak a little bit more about, what we actually can do for allergies and how allergies should be kind of investigated, or what you can do for our childhood allergies as well. Yeah,
absolutely. I wanted this to be a focus of our talk today because we have this question coming up all the time, and there is a lot of need for some more education and so on. So it's really amazing to have a pediatrician, or at least for me to know a pediatrician, because I'm sure there are people out there, but I've just not had the chance. Not everybody is as welcoming as you are in terms of meeting me and chatting through things and so on. So now we're
glad to be of help.
Amazing. Yeah. Okay, so let's just dive right into it. And this is your first time on the Coffee Morning. We want this to be very mummy-centric. So the moms who are on the call, they get an opportunity to speak to you directly, which is often actually what is needed, because there's often lots of questions the pediatrician or the physician will actually ask in order to establish what the actual, issue is.
Yeah.
Because no two allergies manifest in the same way, right? So let's first talk about, what are childhood allergies, and are there different types of allergic responses? I mean, I know the answer is yes, but maybe you want to talk through what they are and what different types of allergies we see, particularly in children.
Sure. So childhood allergy is actually defined as an abnormal body immune response to an exposure of an allergen. And allergens can come in many different forms. So they can be respiratory allergens, and most commonly locally in Singapore with the humidity, the sort of most common respiratory allergen tends to be dust mites. That's something we see really commonly, right? But other respiratory allergens include things like pollen or mold or pet dander, like cats or dogs. You could also be allergic to food particles. So that's where we talk about your 8 common food allergic groups. Actually, now it's become 9 as well. So that is actually cow's milk, soy, egg, wheat, fish, shellfish, peanut, other tree nuts. And then your 9th allergen is kind of sesame. So that's coming up quite commonly as well. And you could also be allergic to drugs, right? So that's only if you're prescribed a medication and then you develop allergies to it too. Yeah, so those are the most common allergic tendencies that people could get. And that's what an allergic response is. It's a body mounting an immune system. So when we talk specifically about allergies, then we are talking about the immune-mediated allergies, right? So the body is exposed to the allergen. And what happens is that your mast cells in different parts of the body actually produce IgE antibodies. So sometimes the first few instances of exposure doesn't actually manifest with an allergic reaction, because that's actually the first contact of the immune system to the allergen. So it takes that first few contacts to then develop an amount of antibody, a sufficient amount of IgE antibody to then subsequently mount the allergic manifestations. So most children also don't present with allergic manifestations in the first few occasions of exposures to food. It's after perhaps the third, fourth, or fifth time that they could present with that.
Okay. So that's really interesting to know that there needs to be a meaningful amount of exposure, and some people never having exposed to a certain thing. Like me, I developed an egg intolerance, for example, when I moved to Singapore, because egg is in everything. And so that was interesting to me. I developed that only as an adult. So it's interesting to see. And that's, I think, where it's so important that mummies and or parents work with an allergist or work with a qualified dietitian. For those moms who have lots of allergies in the families, we know that a lot of this is being passed down to our children in the new genetic mix-up that we have with every baby that we create and grow. So to be a little bit more mindful about how we introduce that and do it safely, right? But I'll let you continue. So IgE antibodies, and we need meaningful exposure. So we don't necessarily see it at the first bite or when my baby licks the rind of bread, but we need, a significant amount to be presenting to the body.
There is one exception to that though. So we do know that certain babies are a bit more predisposed to food allergies and can present with that quite suddenly or immediately, even on first exposures. So those particularly are infants who have a history of infantile eczema. Yeah, so we'll talk about the allergic march as well. And eczema is actually the first presentation of allergies in most cases. So in eczema, what happens is that you have a broken skin barrier, right? So you have red, itchy, dry skin, and that barrier of skin is defective. And that allows environmental exposure far before oral exposure comes in, right? So we have tiny amounts of maybe food particles in the environment at home through preparation, through parents eating it and then touching their babies, and they get sporadic exposures through the skin. So that's actually the immune system's exposure to the allergen initially. And then what happens is that when these babies take foods for the first time, they could flare up with a pretty bad reaction. So that's sort of the exception to what we spoke about in terms of needing a first few forms of exposure. Some babies with eczema do present with reactions even on the first lick or bite of food, like you spoke about as well.
And that's quite scary in a mom to see any type of reaction.
I'm sure it is. So we do, I mean, in clinic, we see lots of first-time parents as well. And weaning is something that is commonly asked about and spoken about. So I think a good time to speak about weaning is usually at about the 4 to 6 month mark, just to sort of prepare everything ahead, both mentally in terms of getting your feeding chairs, everything else that's usually comes with your 4-month vaccinations, that we start introducing this concept of when you would eventually wean and what you need to be prepared for and reactions to watch out for as well. Yeah.
Amazing. I was going to leave that till later because a bit of a contentious zone that I like to pick. And I know
yes, we'll speak about that. No, I'm not saying we should wean it at 4 months, but I'm saying that you should start thinking and speaking about weaning with a pediatrician or doctor when you go in for a 4-month visit, right? Because by 6 months, if you do it then you kind of you delay that a bit more, because you have to put an effort to get your feeding chairs, think about how you want to prepare food, your storage containers, and how you want to progress that on. So then that gets a bit delayed to 6.5 or 7th month if the first time you're thinking about it is at the 6-month vaccination visit. Yeah.
But I'll ask you right here, because I know that there's a new guideline, or the WHO guidelines have been revised. A lot of my clients come to me, or our mummies in the group come to me, and they say, oh, but my pediatrician told me I have to introduce at 4 months. So can you clarify once and for all what the
Yeah, I think this whole weaning issue has been really confusing, especially in the past 5 or 6 years, because there have been variations and different groups dependent on whether it's WHO, the American Academy of Pediatrics, or allergy associations come up with different advices, and that's where it gets a bit confusing. So this whole early weaning in terms of starting solids by 4 to 6 months actually came with some of the evidence in the past 5 years or so that showed us that sometimes starting specific foods slightly earlier, especially in higher risk infants. And when we speak about higher risk infants, they are usually infants, like we spoke about, with a history of eczema or a first degree relative. So either a parent or a sibling with a strong family history of allergies. So either eczema, food allergies, asthma, or allergic rhinitis that puts you at a slightly higher risk, right? So these babies might have slightly reduced tendencies of developing true allergies if we then introduce foods through the gut slightly earlier, right? So there were certain large scale studies and papers, for example, the peanut study that was done by Gideon Leck in the UK. So there was a very big study that probably guided all this earlier introduction of allergens by 4 to 6 months. Mm-hmm. So what this basically showed was that for certain allergens like egg and peanut, if these were introduced earlier to infants who are high risk, then they were at significantly lower risk of then developing these specific allergies. Mm-hmm. So when we speak about these studies, the evidence is specific to mainly 2 foods. So we've tried to look at all the 8 allergenic foods in various cohorts in Australia, in the UK, and in America as well, with different allergenic groups. And the main evidence was actually in purely high-risk infants with eczema, specifically for maybe peanut and egg, right? Yeah. A bit more clear for peanut, but less for egg.
Dr. Mohana, can I just interject here? Because
yes,
I think families may not know, especially being a first-time parents, allergens were previously said to keep until the child is 12 months old.
Oh, yes.
We were being very, very careful. Yes. But this doesn't now mean that that any mom can just go or should just go and at 4 months introduce peanuts.
No.
I want to be very specific because people might listen to this at a later stage and not have the opportunity to ask questions. So be very clear.
Sure. So maybe I'll speak about a normal infant who is not high risk, right? So there's definitely no rush to introduce allergens straight on. The key is actually not to delay the introduction of allergens unnecessarily anymore. So in the past, if we went to maybe our parents' or grandparents' generation, then there was some advice that would tell you, don't introduce any form of cow's milk, not even yogurt or cheese till about 1, right? Eggs till about 2, and maybe tree nuts till about 3. So we now know that delayed introductions also predispose you to forming allergies more. And we want to slowly introduce allergens by the age of 1. So there's no rush to start them at 4 months, right? And for a well infant, we now know that the American Association of Pediatrics as of last year is aligned with WHO and does recommend complementary feeding only from the age of 6 months, right? So there's no rush immediately to start earlier. There are certain medical indications sometimes where pediatricians might then advise you to start earlier than the 6-month mark. That's usually if an infant is falling behind significantly in terms of weight or they're feeding issues with milk, right? But that should be a medical decision with the doctor as well. Otherwise, if the infant is feeding quite well on milk, and we know that milk forms the bulk of food, right, or nutrition to the infant up to at least the age of 1 year, then there's no rush in terms of introducing in terms of quantity or how fast we progress in terms of weaning in that 6 to 12 month mark, right? Yeah. So we also want to make this very stress-free for parents, and that then also encourages infants to explore with foods, right? Different textures, different tastes, and then along the way also introduce allergens. So in the first few weeks of weaning, whether that is from 6 months or if medically indicated earlier than 6 months, for at least the first 2 to 3 weeks, generally I would still advise safe foods which are not very allergenic, right? Because the infant is very new, the whole process is new. We don't know how babies are going to react. We don't want the first food to be something that is allergenic and then you get panicky and we stop the feeding process. Yeah, so we want to go very gently on the stomach with just your fruits, vegetables, nutritious foods. You can focus on iron-rich greens as well, something that would help the gut along, doesn't get them constipated. I always say that water is also a new food to the baby. So when we introduce solids, we want to get a little bit of water in and fluids in as well. And that's also a new food alongside milk, right? So I keep that for the first 2 to 3 weeks to make sure the baby is taking quite well before we decide on moving on with allergenic foods. Yeah.
And I really think that, in families where we do have a predisposition to allergies, I think it's almost even more important not to go this path alone, but to have someone who guides you and says, this is how we not only safely, but also meaningfully introduce these allergens. So I think this is the perfect time to engage someone like you who really knows their stuff, to know how can I do this safely to have the best outcome for my baby, rather than doing it alone and just dabbling a little bit. And then maybe we haven't introduced enough, or maybe we introduced too much at the same time. And we have these scary situations at home where we have an allergic response that is difficult to handle. Now, maybe this is the time where we talk about the differences in allergic responses, because we can obviously have, a simple rash, or it might be quite dangerous and we might have an anaphylactic shock. So maybe talk about the difference and the different gradients of allergic responses.
Sure. So usually the most common manifestation of an allergic reaction would be in the skin, right? So skin, and secondly, perhaps in the gut, because it's oral ingestion. So you would imagine that it could also possibly affect the gut. So skin manifestations usually is things like breaking out into really red or itchy rashes quite soon after ingesting the food. Most allergic reactions would happen quite soon and temporally to exposures to food. So that could be within 5-10 minutes, or even up to, we say, a maximum of 4 hours, but usually it's pretty obvious to the parent, right? Within that half an hour progression of symptoms. So in the skin, other than rashes, you could also get hives. So hives are, of course, a really itchy mosquito bite-like raised rashes. And eye swelling and lip swelling is also considered part of the skin. So you could get angioedema or puffy eyes, puffy lips as well. So those are your most common skin symptoms. And when it's confined to the skin, as bad as it looks, it actually is still considered a mild reaction, right? You could look really puffed up or really red, but as long as you don't have a second sort of component to it or anything that is progressing to more severe symptoms we talk about, it's still considered mild. So what we need to do for a mild reaction is obviously immediately stop the food and not increase the exposure to it, right? And we do give simple antihistamines from the age of 6 months. So again, that safety of introduction of allergenic foods from 6 months, where there's something you could potentially have at home to treat a mild reaction, right? And be more aware of severe reactions where you do need to bring the child into an emergency unit, right, to your doctor straight away. Is quite important. And those simple medications that you could stand by at home are your non-sedating, non-drowsy antihistamines. The most common one is cetirizine, or is known as a brand name of Zyrtec. That's pretty common. So, overseas, sometimes, especially in the US, Benadryl is something that is big or is known, but that's a sedating antihistamine, and we've moved well away from that. So even current pediatricians in the US, the most up-to-date and current ones, wouldn't use Benadryl anymore, right? So that's actually sedating antihistamines should be reserved for children above the age of 2, and because they're drowsy and sedating, may not be very safe for young babies. So always stick to a non-sedating antihistamine. You could keep some Zyrtec that's off the shelf available for your baby if you're afraid when you're starting the weaning process, and this is what you watch out for. The second most common symptoms actually are gut symptoms, right? So it's sometimes hard to tell in a baby unless you obviously have your vomits, or loose stools might come a bit later, but you could also have severe tummy pains. So that could just present with extreme irritability in an infant. So if the behavior changes, it's something to be concerned about as well, right? So obviously that's a persistent change because there's constant pain. So they may be really irritable and cranky for a period of time. Usually it's not isolated. So you may also see some skin symptoms along with that, or, something's a little off, right? And if there's really bad tummy pain, sometimes they curl their legs up to their chest as well, because, there's lots of bad cramps. So those are things that you could watch out for. So mild gut symptoms or skin symptoms are still considered mild allergic reactions, and you could give your Zyrtec. But if that progresses on to something a lot more severe, then you want to get immediate help. You don't just give Zyrtec and wait at home to watch, right? Because we do need to treat with more specific medications in a hospital or clinic setting as well. So when we talk about severe symptoms, then that usually has been, again, redefined in the past year in terms of a consensus of what anaphylaxis is. Yeah. So anaphylaxis is a severe acute life-threatening reaction. So one definition of it definitely is if your blood pressure goes down. So obviously you don't have blood pressure monitors for children at home, but what symptoms do we look out for? We actually look for a very quiet child. A child that quietens down and looks very pale is not good, right? We want an active baby, right? So if there's a change in behavior, they get really cranky, irritable, or the other extreme where they go really pale, quiet, or limp, that's a straight indication you need to go bring the child in straight away to accident and emergency A&E department, right? And you probably do want to call an ambulance in at the same time if there's anything severe like that, to bring you into the nearest children's emergency. In Singapore, the two main children's emergencies, of course, are the KK Women's and Children's Emergency, or if you're living in the West, then the NUH Children's Emergency. So the blood pressure is quite clear. But the other definitions would include severe respiratory symptoms, right? So if your breathing is affected, you start breathing hard and fast, or you start hearing wheezing, then that's not a good sign either. That's a more severe reaction. And your breathing passageway also starts from your mouth and your tongue. So if you start seeing tongue swelling, a hoarse voice change, so that's internal swelling that you cannot see, a very hoarse cry or muffled cry, then those are severe reactions you need to bring the child in for immediately, right? Without waiting or watching. Yeah. And the last thing would be really severe gut symptoms. So in that really cranky child that is not settling at all, or is persistently vomiting and throwing up straight away, then you want to go in. Some sort of in-between indications would be if you feel two systems are involved. For example, if you have a skin symptom, but you start getting really watery eyes, runny nose, a hacking cough, together with that could be respiratory involvement as well. Those are indications not to just treat at home and watch, but to get a medical consult at least to see if this could be something more severe that needs to be treated. Yeah. And
so you would go straight to KKH and NUH, or is it better to go to a closer A&E? How is Parkway East, for example, equipped with, do we need a pediatrician in that case, or can any A&E help?
Okay, so I do think that if the reaction is very severe, it is good to call an ambulance, because in the ambulance, they're also equipped to administer adrenaline if required, right? So the medication that you need would actually be adrenaline, which is an injection that is certainly available at all A&Es, even if they are not pediatric ones. So if you judge that you can reach the A&E at Parkway East, for example, in the East, really quickly, and that would be a lot faster than waiting for an ambulance, and you feel that the child is safe, right? And you can be transported, then that's fine. Because the other thing is that in a severe reaction with that pale, floppy child, blood pressure is affected, you don't want to hold them upright. You actually want to lay them down to keep the blood pressure stable. So we have had rare cases where, the child stands up and then collapses because the blood pressure is already so low and you don't know, right? So if you feel that that looks quite severe, and that's an extreme that doesn't happen as commonly, right? But in that rare instance, and you don't want to be carrying or moving the child, transporting them, but waiting for an ambulance instead. Yeah. But if you feel it's the moderate kind in between, and it's nothing that extreme or severe, and you can get to a nearer A&E, then yes, because all A&E departments would have adrenaline and be equipped to administer that. Right, so you don't need a pediatrician to administer that, because in the other A&Es, obviously the children's A&Es have pediatricians on site, but the other ones would be run by adult physicians. So they would treat them first based on their protocols, and then call in a pediatrician if necessary, or if the child requires admission. Yeah.
That's really good to know. Now, moving back from the really dramatic anaphylaxis, maybe go to something a little bit more benign. How do I know? Yeah. Obviously allergies, but there's also intolerances. And how do I as a parent know what the difference is, or how can I, what is the difference between those two?
Okay, so Allergies are obviously usually quite immediate. So it's the symptoms we spoke about. They're quite clear-cut. They're IgE mediated. They're due to antibodies which are formed. Intolerances is a separate group that it's not really immune mediated. So the most common form of intolerance we know of, maybe in Asia or specifically in Singapore, would be things like lactose intolerance. So intolerances are usually due to slight enzyme deficiencies. So the enzymes are not working as well or processing as well. They can develop over time. So for example, in lactose intolerance, the prevalence of that increases with age because your lactase enzymes get a bit less functional with age, right? So those are usually most commonly gut symptoms. For example, you drink a glass of milk and then you quite soon after start feeling discomfort in your tummy. There could be cramps, lots of gas or bloatedness, and you could pass diarrhea as well, right? And sometimes we have other symptoms out of the gut. So sometimes you feel more lethargic or you get headaches as well. Yeah, so that's lactose intolerance, and you could have gluten intolerance as well, right? And you could also be intolerant to histamine. So that's in like wine or cheeses, which is not as relevant in children. Yeah, so sometimes lactose intolerance and gluten intolerance can come in, and that's more enzyme mediated. It's never dangerous. So it gives us a bit of time to work through those deficiencies as well, because you don't see something severe or dramatic like we spoke about in immediate type reactions. So it's never dangerous. It just gives you more discomfort sometimes, right? And then the last thing that it's not really defined as intolerances, but we know there are also non-immediate type allergic reactions. We call them non-IgE reactions. So those don't come up as soon after exposure to a food, right? So it could be delayed sometimes 2 hours, 6 hours, half a day later as well. And that's because those are responses within the gut immune cells, right? The T cells that respond to it. So sometimes you get inflammation within the gut that then presents also as tummy pains or diarrhea, or you start seeing mucus beds or blood streaks in your stool. So that sometimes happens in children as well. It's quite common with cow's milk in infants. We call it allergic proctocolitis. There could be a component of this in really severe reflux as well. So that's your upper gastrointestinal tract. So if you're a really bad refluxing baby, always cranky, crying, back arching, sometimes there's a component of this non-immediate type reaction as well to cow's milk.
So I have actually, because you mentioned, did you mention celiac? But I don't know if you did.
No.
So the difference between, so I have a mom in the group who sent in a question. She herself is celiac. And now she obviously wants to know, you know, how do I handle this with my child who potentially inherited that? Should we be testing upfront, or can I take a wait and see approach? What would be your best advice for this mom?
Okay, so celiac disease isn't exactly classified as an allergic condition because it's a clear autoimmune condition. So that is taken quite seriously, right? So gluten intolerance is different because it's a non-celiac intolerance. So in celiac disease, you get diagnosed because your body is actually producing antibodies. The gut is producing antibodies against its own cells or the gut wall, right? And that's aggravated by the exposure to gluten. So that is definitely sort of diagnosed objectively based on blood tests that measure these antibody levels, and is done best by a gastroenterologist who then follows you through as well. So we do know with celiac disease that the incidence of it being inherited is quite high, probably about 10%, right? There are clear indications that come on quite early that prompt us to then do a diagnosis, and that usually first starts with the infant not putting on weight very well. So if there's failure to thrive, if your weight is stagnating or coming down your growth lines, then there is a clear first indication to get tested earlier, even before all the other symptoms present, such as diarrhea or loose stools.
So then this brings us to testing, actually. A lot of moms, so what I would like to know is a lot of moms are a little bit hesitant in terms of testing, because testing to us means big needles, you know, very invasive, and they're worried about their little babies. So how do you test in practice? I mean, obviously it depends on what kind of beast we're dealing with? Is this celiac disease? Is this an allergy? Is this just an intolerance? Is there a way to test before the child has even been exposed to certain things? And what does the testing usually involve in your practice?
Sure. So I think an important question to answer is why we want to test more than how. I think that's a very important thing to think about before you go down that route, right? So in terms of what kind of tests we do, usually in younger children and babies, I tend to like to perform more of skin prick tests than blood tests. Because skin prick tests are actually where the allergen extract is applied to your skin as a droplet, and we just scratch the surface of the skin. So it's not like a needle that penetrates through. And because it's not deep, it doesn't touch your pain receptors, and it's usually a painless process. It's also quite quick. So what happens is that if the child is allergic, then there's a wheal or like a hive that forms at the spot where the skin is scratched, and that is read within 15 minutes. So you have like an answer or a result in 15 minutes. So the other way of testing then is your blood tests, right? So all these tests are to measure your IgE responses in the body, whether it's on the skin or through your blood. And we know that usually skin tests are almost as accurate as blood tests, right? They're also a lot cheaper. So in a blood test, I need to draw a blood volume, and dependent on the number of allergens we want to test for, then that quantity varies, right? And we send it out for testing, and usually the results come back in about 2 weeks or so. So we also get delayed results. It might be a bit more costly, and there will be some amount of pain because of blood taking, and blood volumes will vary dependent on the test you decide to order. So then when do we actually do skin testing? Certainly if you have had an allergic response, then your skin test will certainly show up because you have enough IgE in the body, and that will show up in your test, whether it's skin tests or blood tests. In terms of,
sorry, can I just interject?
Yes,
How immediate does that have to be? Like, for example, a mom introduced eggs, she saw a reaction in the child, and then a month later, so she leaves the egg out of the diet, and then a month later she comes. Does that still show in the test?
It will. In fact, we don't test very early. So especially if you've had a severe reaction, right? A more severe one, lots of rashes all over, really swollen, obvious reaction, right? What happens is that some of your antibodies get linked to your mast cells, and they're not free floating in your bloodstream. So actually early testing predisposes you to false negative results. They show up as negative, but that's because your IgE is still linked up to your mast cells and not free floating. So the window, sort of magic window period to wait before testing is actually 4 to 6 weeks from any reaction. So that's when I usually see my patients for testing. If they come earlier, then we kind of evaluate the history and plan that ahead. But we try not to test too early because that might mean you have a negative result and the picture doesn't fit. We want to repeat this again, right? So some parents are anxious and prefer early testing, and sometimes that's done earlier, but you need to bear in mind that actually that's not the best way to do it. So that's why usually we give advice on the identified allergenic food based on the history to avoid that for the next 4 or 6 weeks, right? Not introduce other specific high-risk foods which might be linked, and then do allergy testing to then define and confirm that, and have a follow-up plan of how we then approach the specific allergy. Yeah, so never too early, 4 to 6 weeks onwards, yes, you show it. It takes quite a while for antibodies to wane. So usually if you haven't been exposed for maybe 3 to 5 years, then it may not show up. But if you're doing testing 6 months on, right, it should still show up. So there's no rush in that sense, and yeah, you would still be able to pick it up. The interesting thing if you wait 6 months is that, especially for 2 specific foods, right, milk and egg, lots of children tend to outgrow them. So you could have had a reaction earlier on, and then some parents come 6 months later, they haven't fed the child, and then we find that it's negative, then we want to introduce it in, right, because clearly then the child might be outgrowing already.
Amazing. So that's the good news actually as well, to say something positive today. You know, often these childhood allergies, they are pretty much done and dealt with once the child enters primary school, kind of thing, at the very latest, you know. So it is possible to have reactions but then not suffer for the rest of your life, or not to have to avoid certain foods for the rest of your life. Now,
yeah, they're quite food specific, and we do have certain children where it carries on, but that is a small percentage of overall the larger number of children that do start off with allergies. Yeah.
Okay, and then coming back to the testing now. So for example, my baby showed a reaction to egg. Would you just test this one thing now in the skin prick test, or is there a standard panel that you would recommend once, or is this even an option, for example, for moms or parents who have lots of allergies in the family anyway, to test the big 8 or big 9 or whatever and test them all at once?
Well, yes. So certainly panels are offered very commonly, whether it is on skin prick tests or blood tests as well. And the reason why panels are offered is sometimes just because of the way skin tests are done. So there are many different ways of doing skin tests. Usually we apply each droplet and prick each test, but they're also what we call multi-tests. So certain places might do multi-prong tests where they then fit that prong into a preset well of allergens, right? So then you have certain specific extracts which are already set in, so it's easier to offer that test based on the way you perform the skin test and what is available. I personally don't go for panels as much unless there's certain indications, right? So we usually, the best way of doing a test, whether it's a skin test or blood test, is first to get evaluated by history. So you don't go in blindly and do a whole panel test, right? Because that defeats the purpose. And that's because all tests, whether we're talking about allergies or other blood tests, have a rate of false positive and false negative results, right? So by taking a very detailed history and then first determining what you think the possible food allergens are, whether there's been previous exposures, and whether certain foods are a lot less likely in terms of being allergic at this time point based on the baby's previous exposure, that then increases your post-test probability, right, of diagnosis after doing that specific test. So obviously, if a baby is eating a specific food very regularly already and has had no reactions and no issues, then we don't want to test it, right? Because if you have a false negative test, right, you get a very small bump on your skin prick test or very low level on your blood test. Are you then going to remove the food? Yeah. And that's what, as allergists, we are usually quite afraid of, because sometimes allergy testing is offered quite expensively in many areas. And then the knee-jerk response of the doctor reading the test is then to avoid every tiny positive blood test, right? And we're removing lots of food, which is not necessary to remove from the child's diet as well. Yes.
Okay. I've totally forgotten that, we're already almost 40 minutes in. Mummy's on the call. You may be here for a reason. If any of you want to ask a question and talk to Dr. Mohana directly, I would really appreciate that as well. It would give you more of an opportunity to figure out what you need to know. So let us know by raising your hand or putting something in the chat. And in the meanwhile, we are going to continue on. I do have another question for you that was asked by a mom last week at the coffee morning. And she was basically saying, I breastfeed and my baby seems to be reacting to so many foods that I eat. Can you talk a little bit about that, the response of a baby to certain foods that the mom is eating, consuming, and that manifesting in the breast milk or when the baby takes the breast milk?
That is certainly possible, and usually this can present in both immediate type or non-immediate type reactions. Immediate type reactions through breastfeeding alone is quite rare, but we have seen instances where babies do break out into hives when the mom has a certain allergenic exposure. So if that happens, then you want to go back and think about what you've had to eat in the past half a day or so. Whether there's something out of the usual, you've gone for a fancy meal, there's shellfish or nuts, and then we want to test the baby to see what, because obviously if they have a reaction, then they mount an IgE response, and we can test that as well. So when we talk about testing, usually most of these babies may react from about 4 months onwards. That's when they produce a lot more antibodies as well. So that's usually my lowest age limit of testing. And if you've never had a reaction, and even if you have a high-risk family history, there's no clear indication, you must get a skin prick test or a blood test before feeding, right? So I think the more important thing is to know how to introduce safely right? So when you start your allergens, you want to start with a small quantity, increasing it, doubling it over a specific period of 4 or 5 days, because, you know, reactions might present a few days in. Do that singly without other new foods at the same time. So it's easier to identify the allergen in case of any reaction. And stand by things like Zyrtec, because if you start with a small quantity, that's a small amount of exposure, and the likelihood of a reaction is also milder than to get a whole chunk of egg in the first exposure as well, right? So the reactions are usually linked also to the quantity of allergen that the child is exposed to. So sorry, what were we talking about before I went down this route?
What do you think of that? I mean, I have so many moms that think, you know,
the breast milk, the reactions, right? Yeah. So,
you know,
yes.
So many moms who stop eating altogether.
Yes. So we're talking about the immediate type reactions, which are obvious, right? The hives are obvious. You get fleeting rashes, those are obvious, and those need to be investigated. But the other form of allergies then are your non-immediate type reactions. We were talking about the allergic proctocolitis, the really bad reflux, the non-IgE mediated gut sort of reactions. Those sometimes can really be subtle, but because they're subtle, and because non-IgE reactions are T cells in the gut and they don't show up on skin tests or blood tests, it's sometimes really easy to overread into it or overcall it. So I would be really cautious when I think about these sort of non-IgE reactions, especially through breast milk, right? Usually what happens, for example, in really bad reflux or colic, is that we try to do all the other supportive measures first, right? Whether that is feeding the baby more upright, holding them up more, burping beyond that, right? Because if it's truly a food-related reaction, babies don't get much better with these simple measures, right? Those would be persistent or worsening symptoms. They'll be screaming away in pain with every feed, back arching, despite all these simple measures, limiting small frequent feeds because of your small stomach capacity. Obviously, if things show up a bit more obviously in terms of lots of mucoid stools, black specks or blood streaks in the stools, then you know there is an allergic issue, right? And those don't show up in skin tests. So the way we actually diagnose it is a food diary or a food history. So the mom monitors objectively the foods that she's on for 2 weeks, right? Keeps that written down in a diary, documents the baby symptoms at the same time, whether it's gut symptoms, behavior, vomiting, right? Or stool patterns. And then if we want to exclude a food, I usually go down the most likely food to cause this allergy. So we know that maybe cow's milk is really high on the list. Some mummies, perhaps soy, because soy is about 20% cross-reactive to cow's milk as well. So some mummies and babies need to avoid both. And egg then comes third on the list as well. Sometimes gluten or wheat, a bit lower. Yeah. So we try not to remove everything from the mom's diet at the same time. We sometimes do in really severe cases where it's not clear-cut and symptoms don't improve very quickly because the baby's in pain, right? Then it's easier to remove and introduce back into the mom's diet. But most of the time, we just try to remove one food so then we can, again, objectively monitor the symptoms on the food diary. So if you do remove the food from your diet, do it only for a period of 2 to 3 weeks and keep that symptom diary going, and try to be as objective as possible, because sometimes it's really easy to overread things, especially if you're stressed about the child. And we don't want you to unnecessarily affect your nutrition, because that also is what you're feeding the child. If you keep good nutrition, then your baby's going to gain well, right? And it's not because of allergies and not gaining weight well, but because you're not eating well too. Yeah, so that's really important to be as objective as possible when you look at these sort of non-IgE, non-immediate reactions that could be a possibility. And I think it's important to be guided by a doctor and to always try to reintroduce that back into your diet and not to be off too many foods at the same time. Yeah.
And then how long would you wait? Did you say 3 or 4 weeks before you then start eating that food again and see what difference that makes?
Yeah, it could be between 2 to 4 weeks. So usually I do 2, maximum 3 weeks, and then put that back. So in medical school, right, we've been told that, okay, if you have an allergy exposure, the mom has it in her breast milk, it takes about 2 to 3 weeks to show up and also be removed. But actually, on a practical basis, my patients tell me that it's something a bit different. They probably can see symptoms or changes within a day or two of reintroducing foods or having accidental ingestions of foods they're supposed to be avoiding. So it might actually be a lot sooner than we think as well. Yeah.
Interesting. And what do we actually know about breastfeed? I'm talking about breastfeeding moms now, obviously, about breastfeeding being a safe exposure to certain allergens, in the sense that, if a mom has these, shellfish and gluten and egg and so on in her diet while she's breastfeeding, is that a safe exposure for the baby? How much of that goes through to the breast milk so that we could potentially determine if that baby later down the line will have issues and be reacting to these foods?
So the main guidance and what we know so far is that you don't avoid any allergens in your diet during pregnancy or breastfeeding unless you yourself are allergic to the food. Then obviously you need to avoid it so you don't get an allergic reaction. But otherwise, we actually want to have diet full of allergens as much as you can to continue the exposure to baby. So we don't want to unnecessarily avoid allergens at all if the mommy is not allergic as well. So that's quite important. And unless the baby shows signs of an allergic reaction themselves, then we also don't omit that from the mom's diet.
I really love hearing that, because we've had so many decades now of moms having to avoid so many things in their pregnancy. And I'm glad that the advice on that has sort of backpedaled a little bit.
Yeah, since we're talking about pregnancy, actually, there's a few measures you could take during pregnancy to sort of maybe reduce how much your child is predisposed to developing allergies, even with a really strong family history of allergies, right? So one thing is in terms of keeping a very good, well-balanced diet. And we do know that a slightly more Mediterranean diet with lots of fruits, greens, vegetables is also helpful. If you have a pet at home, then keep that during pregnancy, because dogs and cats can also help reduce your allergic tendencies. We want to continue breastfeeding for as long as you can, because that does help your gut immune system. If you can, of course, deliver naturally, because a cesarean section does predispose you a little higher to allergies. Passing the baby through the vaginal flora actually is helpful for your gut microbiome, and the gut is a huge immune system that you want to keep as well, and that can be protective from allergies. The other things that some people do is to take probiotics from about at least the third trimester onwards and continue that on while breastfeeding for the first 6 months of baby's life. So mommy could take the probiotic and continue breastfeeding. If you come off breastfeeding, then you could serve the probiotic straight to baby. And that's really just to recolonize that whole gut microbiome and help along with the tolerance from the gut itself. So those are the few measures. And if you have a strong family history of eczema, we actually keep the skin moist and really well hydrated from after the delivery, right? So you want to at least moisturize the baby with a very simple, fragrance-free, minimal, chemical sort of a moisturizing cream, head to toe, twice a day. That's helpful too. Yeah.
For me, it starts way earlier. It starts by not wiping the baby down and not removing that beautiful vernix that they have on them, which is so often, unfortunately, standard practice in hospitals. And even as moms, I often see them, obviously, because I'm in the birth room all the time. The tendency is to, want to clean them, but that is so, so important for them to be able to absorb that and so on. I love everything that you've said here, because I think there's so many studies now that show us that giving probiotics in pregnancy or taking probiotics in pregnancy will actually set them up for life and reduce the incidence of allergies. And I love that has gone through to mainstream kind of medicine as well. I have a question for you in the chat, so I will read that to you. So my mommy is asking, hi, Dr. Mohana, I have asthma and eczema, and I used to have food allergies as well. When would you recommend I start to introduce things like dairy, eggs, and nuts to the baby, is what I'm guessing. I am planning to start solids next week as my little one turns 5 months then. I have noticed small patches of eczema already and was considering an allergy test, but maybe I should wait. Thank you for your insight on that.
Yeah. So eczema is usually a skin barrier defect, right? So the key of treating eczema and to reduce food allergies is actually to just treat eczema early. So the less you have a broken barrier, the less exposure to food allergens, and the less likely you are to develop the higher risk of food allergies over time. So treating eczema early is quite important. And that comes with really repairing that skin barrier, using your fragrance-free, soap-free cleansers to strip less moisture off the skin, really lathering on as much of good moisturizer as you can, as frequently as you can, and trying to reduce inflammation through any irritants externally as well, right? So we always want to target eczema. In terms of the risk of food allergies, there is no clear-cut indication, like we spoke about, that you need to do a skin test before introducing foods, even in a baby with mild eczema. So the current guidance is that if the baby has moderate to severe eczema, so very extensive eczema, right, with all over quite lots of patches on the body, then about a third, so about 30% of them may be prone to having a food allergy. So that's a relatively high percentage where parents may want to get skin tested. But then you need to think about what you do after the skin test. Obviously, the skin test is negative, then we want to quickly start introducing the allergens in, because skin tests also change over time. You don't expose the baby to the food in 2-3 months, my skin test also changes because your immune system just is developing so quickly in that first 6 months, right? And you could become allergenic if you don't keep it tolerant by keeping that constant food exposure. So if you're not ready to introduce the allergen, there's no point doing a skin test yet, because that has to come hand in hand, right? And the second thing is then of your false negative results, because sometimes in babies with eczema, because the skin is already so inflammatory, you do get small false negative results, whether it's on blood tests or skin tests. Neither is better. You need to follow that through. So if you don't get a really huge result, what we want to do, and the size of the size of the swelling on the skin test or the level of IgE in your blood test doesn't tell you the severity of a reaction, but how likely you are to be allergic. So a very low test level tells you that there's a low possibility of allergies, and you need to follow that through. So if there's a small positive result, usually what I do is to then go on to an oral food challenge, because that's your 100% confirmatory test. And there are babies who could have really small skin test positive results, but pass their oral challenges, and you want to get those foods in and not avoid it. Because the longer you avoid a food unnecessarily, you increase that risk of developing a true immediate type allergic reaction. So it's not about the testing, but how you follow it through. And if you're confident enough, they've done studies in large scale studies of babies with eczema, whether we need to skin test before or not. And they've shown that the risk of having a severe life-threatening reaction is not lower in a child who is skin tested versus not. Right. So it's not a necessary step. It's no hard, fast rule, but if it helps increase your confidence in terms of introducing foods earlier, then you can do that. But don't wait for an appointment for a skin test and delay introducing the food to your baby.
Okay. I have 2 questions following up on that, and I hope I'll remember my second one after asking this one. So the first one is, so this mom is, the baby is 5 months old. Would you actually recommend that they introduce at 5 months, or would you say that they should wait until 6 months and then introduce? In the absence of any other, advice from pediatricians.
The baby with eczema, right? We're talking about the baby with some mild eczema. Yeah. The current guidance with the latest American Academy of Pediatric guidelines says you can wait till 6 months, right? So if the baby is gaining weight well, there's no feeding issues with milk, you can wait till 6 months. For the first 1 to 2 weeks, I would still introduce your non-allergenic foods first. That's your fruits, vegetables, get everything in, get the baby's gut comfortable, get them comfortable with feeding, get yourself comfortable with the routine of feeding before you go on to the allergens. And if a baby specifically has eczema, then the evidence for introducing 2 allergens specifically, maybe slightly earlier, would perhaps be peanut butter, nut butters, which have to be diluted down for safety because they're quite thick, and egg, which is usually introduced in the form of hard-boiled egg first, because the longer you cook an egg, the less allergenic it becomes. And we start off with egg yolk first, mashed down, diluted down, because yolk is less allergenic than white. So the evidence medically is actually to perhaps introduce those 2 allergens first, because there could be a possibility of reducing the risk of those allergies in babies with eczema, and then moving on to the other allergens gradually. And do this as a slow process over 4 or 5 days, and introduce a new allergen every week or 2 weeks as well, right?
Okay, we have time for 2 more questions, and one is my own.
Okay, sure.
Second. So one is, as we introduce foods and especially allergens, what do you think of doing the skin, doing the skin patch test first, introducing the skin onto the food onto the skin and seeing if there's a reaction to it? Would you do that first?
I think that's a great idea. That's something you could do at home, right? So it has a similar concept to what we do in terms of the skin prick test, except we don't break the skin barrier, right? To have a wheel. But yeah, so that's a rub test, right? So you could either rub it on the skin, or we also rub it on the lip.
Okay.
Yeah, so you could take a lick of peanut butter, just rub it on the lip the first time. You don't need to wait a whole day before you introduce more of it. You could just wait 15-20 minutes. So that's where we're talking about the amount of allergenic exposure, then predisposing to severity of reaction. So if you start with a tiny amount, then obviously the reaction could be milder, and it gives you confidence to then move on with a higher amount in the next 20 minutes, half an hour, and increase that. That's actually what we do during an oral food challenge in clinic. And the clinic-based ones are done because the child has maybe a positive test, which then possibly tells you that they could have an allergic reaction, and that's why it's done in a hospital or clinic setting, right? So we start with a tiny bit, and then we weigh them and increase them, and we feed the child every 20 minutes until we reach a meal-sized portion. So it's done faster, quicker with monitoring in clinic, but you can do an extended version at home as long as you're confident to watch for reactions and safety. Yeah.
We've got a long question here that I do want to get in before we finish. My 9-month-old has had allergic reactions before, and the first and only eczema flare up around 6 to 7 months old. The dermatologist thought it was triggered by a virus. She then had a panel skin prick test done, but I felt it wasn't accurate because after that I introduced egg, which wasn't supposed to cause any reaction, but it did, and it lasted 24 hours. However, lately she doesn't fall sick so often, and I tried to give her the foods that caused the issues before, and she doesn't show any reaction in eczema. But I am scared to introduce allergens. What do you think I should do? Start introducing allergens or do some testing beforehand?
I don't need to answer this question because the mom has answered it herself. She says she's scared, right? So if you're scared, then obviously you're not going to introduce the allergens, and that's where we do skin testing for you. So a lot of it is also to overcome that mental barrier, right? Because if the skin test is negative, obviously that's going to increase your confidence in introducing the allergen. So the whole idea of skin testing is really a balance between whether the parent is going to introduce the allergenic food to the child safely versus parental anxiety and delayed introduction, which then predisposes the child to an increased risk of developing true food allergies. So if you're not afraid, I would say go introduce it. But if you're afraid, then because of perhaps a severe reaction before, then we really go ahead and test because I want those foods in. Yeah.
Yeah, amazing. Just this same mom is asking, I have another 9-month-old who doesn't have allergic reaction, but I noticed that he gets skin bumps that look like eczema, like e.g. yogurt. I don't know if it looks like yogurt or is it when they give yogurt?
Probably when they give yogurt, yeah. So if they are little skin bumps, not really hives, not red patches, then they're not true immediate type reactions. Eczema is quite tricky because we know the food sort of contribution to it can both be immediate type reactions, and we know that immediate type reactions are more dangerous because it could potentially be more severe. So if there's an immediate type reaction, you're swelling, immediate flares right after the food, then you want to stop the food and get evaluated. But if it's something you're not too sure about, usually it's not an immediate type reaction. You get a little bit of dots around, right? A little bit of bumps. It's not an obvious bad reaction. Then usually you can feed through it if you want to. The only thing with eczema is that you could have a mix of non-immediate type reactions as well, right? So your eczema flares consistently could also be that non-immediate type reaction from a food, which would then not show up on your skin or blood tests. So that's where your food diaries and really being a bit objective about it, introducing the food head on for 2 weeks, watching the skin, right? And getting out of that flare and then removing that out of the diet, trying to reintroduce back 2 weeks later. Does it still cause a flare? Then, hey, okay, I think I need to withdraw that from my kid's diet and get control the eczema better and maybe try reintroduce that back in a month or two. Again, I won't hold foods off for a long time because we have seen these turn into immediate type reactions, which then stay on for longer. Yeah, so if there's a need to withdraw, it is to treat the skin better, to get the eczema under control, and then reintroduce the food as soon as we can. Yeah.
Amazing. Clearly, mummies, this topic is so exhausting. And there's so much to know about this. And this is why we love having Dr. Mohana here. Now, your new clinic, Petite Clinic, is in Joo Chiat Road. I will post the details under the Facebook Live so that people can see it at a later stage and contact you. And I encourage you to really have Mohana by your side as you go down that path of, tackling allergies and so on. Thank you so much, Dr. Mohana.
Thank you so much for having me. Allergies is always an interesting topic. Everyone always has really interesting questions, so it's quite fun to have allergy talks as well.
And for
thank you so much, Joanna.
Thank you so much. Okay, thank you. Bye.